PALS Practice Test 2026 Part 4 Arrhythmias and Cardiac Arrest.
Question 1. What defines symptomatic bradycardia in a pediatric patient? Option A. A heart rate less than 100 bpm. Option B. A heart rate less than normal for age accompanied by signs of poor perfusion or respiratory distress. Option C. A heart rate less than 60 bpm with no symptoms. Option D. Any heart rate less than 80 bpm.
The correct answer is option B. A heart rate less than normal for age accompanied by signs of poor perfusion or respiratory distress. Symptomatic bradycardia is a slower than normal heart rate for the child's age accompanied by cardiopulmonary compromise, poor perfusion, hypotension, altered mental status.
Question 2. What is the most common cause of bradycardia in children? Option A. Congenital heart defects. Option B. Hypoxia. Option C. Drug overdose. Option D. Vagal stimulation.
The correct answer is option B. Hypoxia. Hypoxia is by far the most common cause of bradycardia and subsequent cardiac arrest in pediatric patients. Always ensure adequate oxygenation and ventilation first.
Question 3. A 3-year-old has a heart rate of 50 bpm and is poorly perfused. Despite adequate oxygenation and ventilation, the heart rate remains 50 bpm. What is the next step? Option A. Administer epinephrine 4. Option B. Begin chest compressions. Option C. Perform synchronized cardioversion. Option D. Administer atropine.
The correct answer is option B. Begin chest compressions. If a child's heart rate is 60 bpm with poor perfusion despite adequate oxygenation and ventilation, you must immediately begin chest compressions.
Question 4. During CPR for bradycardia with poor perfusion, what is the first-line medication? Option A. Atropine. Option B. Adenosine. Option C. Epinephrine. Option D. Amiodarone.
The correct answer is option C. Epinephrine. Epinephrine is the primary drug for symptomatic bradycardia that persists despite oxygenation, ventilation, and CPR.
Question 5. What is the standard 4/IO dose of epinephrine for pediatric bradycardia and cardiac arrest? Option A. 0.1 mg per kilogram. Option B. 0.01 mg per kilogram, 0.1 ml/kg of the 0.1 mg/ml concentration. Option C. 1 mg per kilogram. Option D. 0.5 mg per kilogram.
The correct answer is option B. 0.01 mg per kilogram, 0.1 ml/kg of the 0.1 mg/ml concentration. The standard 4/IO dose of epinephrine for pediatric resuscitation is 0.01 mg per kilogram. It should be repeated every 3 to 5 minutes.
Question 6. When is atropine preferred over epinephrine for pediatric bradycardia? Option A. For all cases of bradycardia. Option B. When the bradycardia is caused by increased vagal tone or primary AV block. Option C. When the patient is hypothermic. Option D. When the patient has hypoxia.
The correct answer is option B. When the bradycardia is caused by increased vagal tone or primary AV block. Atropine is indicated specifically when the bradycardia is caused by increased vagal tone, cholinergic drug toxicity, or primary AV block.
Question 7. What is the typical heart rate for sinus tachycardia, ST, in an infant? Option A. Usually less than 220 bpm. Option B. Usually greater than 220 bpm. Option C. Usually greater than 250 bpm. Option D. Less than 150 bpm.
The correct answer is option A. Usually less than 220 bpm. Sinus tachycardia in infants is typically less than 220 bpm. It usually has a known cause, fever, pain, volume loss, and exhibits beat-to-beat variability.
Question 8. What is the typical heart rate for supraventricular tachycardia, SVT, in an infant? Option A. Less than 150 bpm. Option B. Less than 220 bpm. Option C. Usually greater than 220 bpm. Option D. Usually exactly 180 bpm.
The correct answer is option C. Usually greater than 220 bpm. SVT in infants is typically characterized by an abrupt onset, no beat-to-beat variability, absent P waves, and a rate usually greater than 220 bpm.
Question 9. Which ECG characteristic helps differentiate SVT from sinus tachycardia? Option A. SVT has visible normal P waves. Option B. SVT typically lacks visible P waves and has an abrupt onset/termination. Option C. Sinus tachycardia has an abrupt onset. Option D. SVT has a wide QRS complex.
The correct answer is option B. SVT typically lacks visible P waves and has an abrupt onset/termination. In SVT, P waves are often absent or abnormal, the RR intervals are perfectly regular, and the onset and termination are abrupt.
Question 10. A 4-year-old child presents with a narrow complex tachycardia at 200 bpm. The child is stable, alert, and has normal blood pressure. What is the initial treatment? Option A, synchronized cardioversion. Option B, vagal maneuvers, e.g. applying ice to the face. Option C, defibrillation. Option D, administer amiodarone.
The correct answer is option B, vagal maneuvers, e.g. applying ice to the face. For a stable patient in SVT, the first intervention is to attempt vagal maneuvers, such as the application of an ice pack to the face, without occluding the airway.
Question 11. If vagal maneuvers fail, what is the first-line medication for stable SVT in children? Option A, amiodarone. Option B, epinephrine. Option C, adenosine. Option D, lidocaine.
The correct answer is option C, adenosine. Adenosine is the drug of choice for SVT. It must be given by rapid force/IO push due to its extremely short half-life.
Question 12. What is the correct first dose of adenosine for a pediatric patient? Option A, 0.5 mg per kilogram. Option B, 0.1 mg per kilogram, maximum 6 mg. Option C, 0.2 mg per kilogram, maximum 12 mg. Option D, 1 mg per kilogram.
The correct answer is option B, 0.1 mg per kilogram, maximum 6 mg. The first dose of adenosine is 0.1 mg per kilogram, up to a maximum single dose of 6 mg, administered as a rapid push.
Question 13. If the first dose of adenosine is ineffective, what is the second dose? Option A, 0.1 mg per kilogram. Option B, 0.2 mg per kilogram, maximum 12 mg. Option C, 0.5 mg per kilogram. Option D, 6 mg flat dose.
The correct answer is option B, 0.2 mg per kilogram, maximum 12 mg. The second dose of adenosine is doubled to 0.2 mg per kilogram, up to a maximum single dose of 12 mg.
Question 14. A child presents with SVT and is hemodynamically unstable, altered mental status, severe hypotension. What is the immediate treatment? Option A, vagal maneuvers. Option B, adenosine. Option C, synchronized cardioversion. Option D, defibrillation.
The correct answer is option C, synchronized cardioversion. For any unstable tachyarrhythmia with a pulse, narrow or wide complex, the immediate treatment is synchronized cardioversion.
Question 15. What is the initial energy dose for synchronized cardioversion in a pediatric patient? Option A, 2J/kg. Option B, 4J/kg. Option C, 0.5 to 1J/kg. Option D, 10J/kg.
The correct answer is option C, 0.5 to 1J/kg. The initial energy dose for synchronized cardioversion is 0.5 to 1J/kg. If this fails, the dose can be increased to 2J/kg.
Question 16. A patient presents with a wide complex tachycardia, ventricular tachycardia. The patient is pulseless. What is the immediate action? Option A, synchronized cardioversion. Option B, CPR and unsynchronized defibrillation. Option C, administer adenosine. Option D, administer amiodarone.
The correct answer is option B, CPR and unsynchronized defibrillation. Pulseless ventricular tachycardia, private, is treated the same as ventricular fibrillation, VF, immediate high-quality CPR and defibrillation.
Question 17. What is the initial energy dose for defibrillation of a shockable rhythm, VF/private, in children? Option A, 0.5 J/kg. Option B, 1 J/kg. Option C, 2 J/kg. Option D, 4 J/kg.
The correct answer is option C, 2 J/kg. The first shock for defibrillation is delivered at 2 J/kg.
Question 18. After the first shock of 2 J/kg for VF, what is the energy dose for the second shock? Option A, 2 J/kg. Option B, 4 J/kg. Option C, 6 J/kg. Option D, 10 J/kg.
The correct answer is option B, 4 J/kg. The second defibrillation dose is 4 J/kg. Subsequent shocks should be equals 4 J/kg, up to a maximum of 10 J/kg or the adult dose.
Question 19. What must you do immediately after delivering a shock from a defibrillator? Option A, check for a pulse. Option B, assess the ECG rhythm. Option C, resume CPR starting with chest compressions. Option D. Administer epinephrine.
The correct answer is option C. Resume CPR starting with chest compressions. Immediately after delivering a shock, you must resume CPR for 2 minutes, starting with chest compressions, without pausing to check the rhythm.
Question 20. During a cardiac arrest with VF/private, which antiarrhythmic medication is recommended after the third shock? Option A. Atropine. Option B. Adenosine. Option C. Amiodarone or lidocaine. Option D. Magnesium sulfate.
The correct answer is option C. Amiodarone or lidocaine. Amiodarone, 5 mg per kilogram, or lidocaine, 1 mg per kilogram, can be administered for shock-refractory VF or private.
Question 21. What are the two non-shockable rhythms in pediatric cardiac arrest? Option A. VF and private. Option B. SVT and sinus tachycardia. Option C. asystole and pulseless electrical activity, P. Option D. Heart block and bradycardia.
The correct answer is option C. Asystole and pulseless electrical activity, P. Asystole and P are non-shockable rhythms. Treatment consists of high-quality CPR, epinephrine, and searching for reversible causes.
Question 22. What is the correct treatment sequence for asystole or P? Option A. Shock at 2J/kg then CPR. Option B. CPR and epinephrine administered as soon as possible. Option C. Administer amiodarone then CPR. Option D. Synchronized cardioversion.
The correct answer is option B. CPR and epinephrine administered as soon as possible. For asystole/P, begin CPR immediately and administer epinephrine 0.01 mg per kilogram as soon as 4/IO access is available, repeating every 3 to 5 minutes.
Question 23. Which of the following is an H in the HS and TS of reversible causes? Option A. Hyperglycemia. Option B. Hypertension. Option C. Hypovolemia. Option D. Hemorrhoids.
The correct answer is option C. Hypovolemia. The H's include hypovolemia, hypoxia, hydrogen ion, acidosis, hypoglycemia, hypo-/hyperkalemia, and hypothermia.
Question 24. Which of the following is a T in the HS and TS of reversible causes? Option A. Tachycardia. Option B. Trauma. Option C. Tension pneumothorax. Option D. Tetralogy of Fallot.
The correct answer is option C. Tension pneumothorax. The T's include tension pneumothorax, tamponade, cardiac, toxins, and thrombosis, pulmonary or coronary.
Question 25. A child with a prolonged QT interval goes into a polymorphic ventricular tachycardia, torsades de pointes. Which medication is indicated? Option A. Adenosine. Option B. Amiodarone. Option C. Magnesium sulfate. Option D. Calcium chloride.
The correct answer is option C. Magnesium sulfate. Magnesium sulfate, 25 to 50 mg per kilogram, is the specific treatment of choice for torsades de pointes.
Question 26. Which intervention has the greatest impact on survival in a pediatric patient with ventricular fibrillation? Option A. Early intubation. Option B. Administration of epinephrine. Option C. High-quality CPR and early defibrillation. Option D. For fluid administration.
The correct answer is option C. High-quality CPR and early defibrillation. High-quality, uninterrupted CPR and early, rapid defibrillation are the most critical interventions for surviving a shockable cardiac arrest rhythm.
Question 27. What is the maximum single dose of amiodarone for a pediatric patient in cardiac arrest? Option A. 150 mg. Option B. 300 mg. Option C. 500 mg. Option D. There is no maximum.
The correct answer is option B. 300 mg. The pediatric dose for amiodarone is 5 mg per kilogram, up to a maximum single dose of 300 mg, the standard adult dose.
Question 28. You are performing CPR on an intubated child. The PETCO2 reading is consistently 10 mm Hg. What should you do? Option A. Decrease the rate of compressions. Option B. Administer sodium bicarbonate. Option C. Improve the quality of chest compressions. Option D. Stop CPR to check a pulse.
The correct answer is option C. Improve the quality of chest compressions. A PETCO2 less than 15 mm Hg during CPR indicates poor cardiac output. You should evaluate and improve the quality of chest compressions.
Question 29. During resuscitation, the capnography suddenly jumps from 12 mm Hg to 38 mm Hg. What does this indicate? Option A. The ET tube is blocked. Option B. Return of spontaneous circulation, ROSC. Option C. The patient has a pneumothorax. Option D, severe acidosis.
The correct answer is option B. Return of spontaneous circulation, ROSC. An abrupt and sustained increase in PETCO2, typically to equals 35 to 40 mm Hg, is a strong indicator of ROSC.
Question 30. If an infant has a heart rate of 250 bpm and prolonged capillary refill, what is the most appropriate next step if FOR access is not readily available? Option A, attempt FOR placement for 10 minutes. Option B, wait for the heart rate to slow naturally. Option C, perform immediate synchronized cardioversion. Option D, administer oral antiarrhythmics.
The correct answer is option C. Perform immediate synchronized cardioversion. If the patient is unstable, prolonged capillary refill, poor perfusion, and FOR access is not immediately available, do not delay, perform synchronized cardioversion.